Good afternoon and welcome to the second webinar of 2021 in the ACCP Immunology and Transplantation PRN webinar series. My name is Matt Harris and it is my pleasure to moderate today. Today's webinar is titled Establishing, Leading, and Growing PGY2 Solid Organ Transplant Residency Programs, and we are honored to have several great speakers with us today. First is Dr. Anders, who is a clinical pharmacy specialist in abdominal transplant and clinical supervisor for transplant and infectious diseases at Ochsner Medical Center in New Orleans. She initiated the solid organ transplant pharmacy residency at Ochsner in 2011, where she served as RPD until 2018. She has served as a guest surveyor for ASHP since 2013 and also serves on the BPS Specialty Council for solid organ transplant. We also have Dr. Diamond, who is a clinical pharmacy specialist in abdominal organ transplant at Temple University Hospital, where he serves as the residency program director for the PGY2 solid organ transplant residency since 2018. Next, we have Dr. Sam, who serves as a pharmacy clinical coordinator at Baylor University Medical Center, where she serves as the residency program director for the PGY2 solid organ transplant residency since 2020. And finally, we have Dr. Yakubu, who is a solid organ transplant pharmacy specialist at Virginia Commonwealth University Health System. He has been a solid organ transplant residency director since 2020. In a moment, I will turn it over to our speakers to begin the presentation, but first, here are a few quick notes. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will answer questions at the completion of the presentation. There will be an evaluation for this webinar available at its conclusion. We encourage you to complete this to let us know how we did and how we can improve our webinars going forward. The slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. If you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through the chat functionality. There is also a live chat in the upper right-hand corner of your screen where you can get live technical support from any meeting. Now, without further ado, I will turn it over to Dr. Sam.
Good afternoon, everyone. We thank you for joining us today. As a group, we are very excited to review with you pearls for establishing, leading, and growing PGY2 solid organ transplant residency programs. I think for me, it's probably what I wish I knew before I got started. Our objectives for this talk will be to describe PGY2 program justification strategies, to recognize optimal learning experience and preceptor development, discuss incorporation of specific longitudinal responsibilities, as well as summarize the ASHP residency accreditation survey process and readiness. So I'm going to take it back to the start and focus on justifying your PGY2 program. I think in embarking on this journey of developing a PGY2, it's always imperative to start with your why, as it will really allow us to create the framework for justifying resource allocation. Anyone who has gone through C-suite discussions knows you have to have your elevator speech ready to go. And not only that, residency development requires tremendous support, not only at the institutional level, but also amongst preceptor teams who are going to be investing quite a bit of time into the training and development of your trainee. So I think the first task is really to think through the value added by a PGY2. And this classic ACCP white paper from 2010 does a great job. This is focused on the value of conducting pharmacy residency training, the organizational perspective, and it really provides the framework for several benefits offered by a trainee. And, of course, this was both PGY1s and PGY2s, but I think we can use the same framework for applying to a transplant PGY2. What the authors described included financial benefits, avenues for practice advancement, as well as support for continued innovation, just to name a few benefits. Now, we can, again, use the same framework for the solid organ transplant trainee as well. I mean, we know particularly in the setting of COVID, many of us have experienced barriers in expanding service lines. So an extender can really allow us to expand our services wherever our clinical gaps exist. So it might be in clinic, it might be in weekend coverage, it might be in a new service line. Certainly involvement in pre-transplant activities, CMS requirements, as well as a QAPI process are amongst a multitude of areas where our trainees contribute to quality and regulatory compliance. Other benefits include increased capacity for programmatic education and research, as well as areas for continued preceptor development. Not to mention, it certainly is a plus for pharmacist recruitment to have a solid organ transplant PGY2 at your program. I think last but not least, it allows us to really create that pipeline. I think even now we still don't have sufficient programs, and we continue to see, which is wonderful, the expansion of pharmacist opportunities as we continue to expand clinics across various programs. And certainly creating a pipeline is very important for our community to continue to ensure high quality or high, caliber of pharmacists who can really serve our patient population. And certainly creating your own internal pipeline has a lot of financial benefits in and of itself. You certainly are able to forego a lot of recruitment and orientation reduction efforts or orientation avoidance by having someone who's already within the system that you could integrate into your practice. So I think if you've then come to the acknowledgement that it is worthy to pursue a PGY2 and it adds value, it's important to then assess whether you as a program, you as a department, have the resources for conducting an effective residency program. If you are pursuing ASHP accreditation, then I think it's important to start with reviewing the ASHP standards, which will really be your Bible as residency leadership and preceptors. And this will be key to understanding requirements for the program, for the residency, for the RPD and preceptors, as well as for the organization. ASHP, which accredits programs, offers this online self-assessment tool, which helps you determine your readiness. And it goes through a lot of the accreditation standards, it goes through some of those regulations, as well as key elements for residency program development. And it takes inventory of some of the basic components, which will allow you to determine if you have support to begin a residency program. So this will include, having preceptor resources, including qualified RPDs and preceptors. It allows you to determine whether you have adequate organization sponsorship, the organizational structure of the program, as well as optimal pharmacy services for being a site of residency or trainee development. Once you have determined whether you have adequate support at the organizational level, it's important to then pursue funding sources. Certainly, unlike PGY1s, this can be a barrier for PGY2 expansion as a whole, regardless of whether it's transplant or non-transplant, because we don't have CMS pass-through funding. But there are a multitude of other opportunities that can be pursued, including partnerships with your local schools of pharmacy, partnerships with transplant programs. There's also the ASHP residency expansion grant that it is one time, but it does offer a good chunk of change to help offset the initial costs or initial first year costs of the program, as well as other institutional grants or education funds that your department may have. It's also important to note that if you don't succeed at first, continue to try again and use a multitude of different funding avenues. And sometimes you do have to get creative. And of course, it's important to consult other RPDs, your own mentors who have been through this process already, and of course, ASHP who have a multitude of resources proposal. And in your, there you go. In your business plan, then it's important to get your data ready. And this is where gathering the best one elective to gather data on the impact of adding a end up developing. And then, of course, it's creating that elevator speech for your C-suite.
Hey, Teena, we're having a little bit of trouble with your audio. I'm not sure. You're cutting out quite a bit.
There you go. And lastly, before I turn it over, I just want to show and create a compelling return on investment proposal to share with our C-suite.
Hey, Matt, this is Adam. Can you hear me? Teena was kind of in and out. I'm not sure if she finished talking or not.
Yeah, I think she's done. We can hear you loud and clear. I'll pipe up if you start to cut out.
Okay, great. All right. Well, thank you, Teena, for that great introduction. I think, setting the stage to establish your program's purpose and potential benefits to the institution is really key in getting things off the ground. I wanted to thank the programming committee for inviting me to speak today. We're going to talk about building core and elective learning experiences and incorporating preceptor development next. Once approval is achieved for your program, you really have to think about how you're going to structure your curriculum. And ASHP has quite a bit of guidance on this, on what their expectations are for core or elective learning experiences. There's a really comprehensive document that is continuously updated. I believe the last update was in March of 2019. And I would recommend for everyone who is on the call who may be thinking about starting a program or in the midst of changing their structure or kind of reevaluating the experiences they offer, to review that document. I'm sure many of us on the call have seen it quite a bit, but it basically really kind of reviews the competency areas, goals, and objectives for PGY2 residencies, and then specifically appendices and objectives for solid organ transplant pharmacy residencies. For anyone who's on the call who may have a residency program that's not ASHP accredited or is not pursuing ASHP accreditation, this document will still provide you with some ideas on how to incorporate certain learning experiences that ASHP recommends. And I'll kind of go through with everyone, what the requirements really are for core learning experiences, sort of what the expectations are, whether that's regarding specific organ transplant populations that the resident requires exposure in. Is there acute ambulatory care components that are required or elective? And really the goal from ASHP, and I think amongst all of us practicing in transplant here, involved in the training of PGY2 solid organ transplant residents, is really for them to really understand the statement that I have here on the last bullet on understanding disease state management and pathophysiology, pathogenesis in regards to conditions related to transplantation, whether that is post-transplant, pre-transplant, and organ management, and organ disease management, and really coming up with a comprehensive pharmacotherapy treatment plan. And that's really sort of how the design from ASHP has come to be, with that full goal in mind. And the core experiences, really, it's sort of up to the program on what would they determine as core versus elective experiences, but really always kind of coming back to what's specifically pertinent to transplant pharmacist training and developing a transplant pharmacist knowledge base prior to graduation and going out into the real world. And ASHP specifically comments on requiring training in at least 2 of the following transplant populations, but it's kind of a loose guideline because there's really no defined, you need to do X amount of transplants in order for it to be sufficient. There may be some additional recommendations from surveyors. We had that feedback on one of our organ populations and trying to, beef up the exposure for the transplant resident, which I'll kind of talk about how we did that, because I know some centers struggle with not having all of these populations on site and relying on other centers or other neighboring centers to take their resident. But realistically, to be qualified for ASHP accreditation, you have to have at least 2 of the following transplant populations, whether it's heart, intestine, kidney, liver, lung, and pancreas, at least 2 of those incorporated throughout the year. And the way around this is if you only do kidney and liver transplant, for example, at your center, trying to think outside the box and thinking about, okay, can I set up contracts with outside institutions, particularly if you have a low volume in a certain organ population, or if you just don't have that organ population at all. Thinking about neighboring transplant centers, which most of us may have access to, because the most transplant centers in major cities, but not all, and trying to set up contractual relationships with those centers. These things do take time, and from my own personal experience, trying to set up a elective pediatric transplant rotation, because we do not do those types of transplants on site here at Temple. It does take quite a bit of time. A lot of centers have different restrictions on contract relationships and certain criteria for screening for the residents prior to coming on site. For example, pediatric transplant centers having higher child abuse clearances and things like that. So just planning in advance as much as possible if you are pursuing a contract or just an elective experience at an outside institution where the resident is not their primary home for their residency year. But definitely think about that as a way to incorporate a lot of these other organ populations. Additionally, as Teena mentioned, some restrictions and barriers with COVID-19. If you're unable to do so, we were unable to do that this year because of COVID-19 restrictions and having our resident go to an outside center. But there will be virtual opportunities that you can think outside the box. Probably thinking about attending virtual rounds or virtual selection committee meetings, or even having virtual topic discussions in that specific organ population. And really just having a discussion with colleagues and reaching out to other fellow RPDs or other transplant pharmacists that especially in your area. Lots of areas will have transplant pharmacist community gatherings, or they used to at least, maybe they're virtual now, or transplant pharmacy community groups where they can kind of bounce ideas off each other into expanding the training experience for the resident. ASHP does require, or I should say expected, they really use the word expected to have the resident involved in the ambulatory practice setting. So really trying to think about how you're going to incorporate ambulatory practice as it relates to transplant. This does not need to be a longitudinal experience. It really can be designed however the program needs to be structured based on communication with your preceptor group, or you have access to maybe physician preceptors that want to be able to take a resident in clinic with them. I would recommend, if possible, to try to incorporate it longitudinally. Doesn't mean you have to do it that way. That works well for our program, and I'll kind of talk about what we've done to sort of include the ambulatory practice setting. But this is really a way to hit sort of the longitudinal pre-transplant evaluations experience for the resident, and eventually trying to foster that independent approach to that, whether it's recipient, live donor evaluations, attending the multidisciplinary selection committee meetings, and trying to incorporate post-transplant clinic wherever you can. At our center, my group of preceptors and I had met multiple times kind of figuring out how we're going to incorporate this. And we've sort of decided on a longitudinal clinic experience, which has sort of worked for the past couple of years. So in the very beginning of the year, we've chosen an every other week type of approach, picking a day of the week where there'll be an abdominal organ transplant clinic, followed by heart transplant clinic, followed by lung transplant clinic throughout the year. And this has sort of worked to incorporate that longitudinal clinic experience, but not to take the resident away from the current rotation they're on too much. by having that every other week incorporated in there. So just an idea to throw out there, a way to include ambulatory practice. And of course, when you're on like, an actual rotation, like on abdominal organ transplant or on heart transplant rotation experience, you can incorporate clinic that way as well, which we also do. So determining if it's elective or core, really the difference is up to you, as long as you kind of abide by the expectations and having sufficient organ populations, at least the 2 of those organ population experiences, and incorporating ambulatory practice. I would just always recommend us to meet with your residency advisory committee or steering committee at your institution and trying to generate ideas from all of your preceptors. People may be able to think outside the box of ways that they can, expand certain elective or core experiences. But there is specific definition as far as elective experience options from ASHP. They're all listed for you here. I kind of put some notes in parentheses as sort of my opinion approach to this. Advanced critical care, I kind of decided to put it as a combined into a core experience. It kind of works out for us with a cardiovascular ICU surgery service where there's also fresh heart and lung transplant patients that are admitted to that service. So it incorporates transplant and touches transplant, but it still provides that advanced critical care, LVAD, CABG, post-op valve repair management, for example. I would always try to say linking these things to transplant would be ideal. So if you have an advanced critical care option you want to offer the resident, trying to use it in an ICU where there may be fresh post-op transplant patients. Clinical research, of course, having a longitudinal research aspect to the program required, and then more if you can provide to the resident, as most of us would do. Bone marrow transplant, having as an elective, if you have that as an option, typically remains elective, not usually a core experience. I'm going to skip corneal transplant because I'm not sure how many centers actually have this opportunity, but anything that's out of the ordinary, I would say, whether it's corneal or vascular composite allograft transplant, trying to usually keep those as elective options, but definitely an option for the resident if you have access to it. Pediatric transplant, this kind of depends on center by center. If you have a robust population, definitely considering it as a core experience, if you can. If not, typically remaining elective. And then for transplant infectious diseases, this is something that likely will be seen throughout all rotation experiences. So probably recommending for it to be core if it's available option for your center. I threw in here, I'm not going to go through this in too much detail, but I wanted to throw in here for your reference how we approach this and sort of what our progression throughout the year is. This is not perfect by any means. It's always constantly in the works and changing, but we sort of try to approach having a bunch of our core experiences up front to kind of give residents exposure to heart, lung, liver, kidney, pancreas transplant in the very beginning, just to kind of give the residents an opportunity to figure out where they may want to practice, prepare them for mid-year and PPS interviews and looking for job opportunities, kind of figure out what they don't like. And in addition, I kind of put some bullet points like what patient populations they'll be exposed to. So for example, the CVICU, heart transplant, mechanical circulatory support rotations sort of meant to give that first rotation to provide exposure to ICU, fresh transplant patients and complications. And this is their advanced critical care is kind of upfront. Usually these residents are coming in with some type of critical care exposure as a PGY1 resident. And then sort of incorporating that ambulatory inpatient kind of combo experience when they go to abdominal organ transplant, breaking for some research time to allow them to collect data for their project to have sufficient time to submit to the American Transplant Congress. Idris will talk about that a little bit too. And then kind of falling into the lung transplant field here right before mid-year usually occurs. So they're kind of preparing themselves for future job opportunities. And then as time goes on, kind of moving into the second half of the year, transplant infectious disease we've determined to be core. It's sort of an opportunity for our resident to have like a highly independent experience where they're rounding directly with a smaller team and an ID attending and an ID fellow, trying to maybe identify a rotation experience where you're really putting the resident in a real independent role in a smaller team where they really are heavily reliant on that person to kind of really give them that autonomous experience. And then throwing in some elective options there based on the resident's interests, and then kind of coming back and circling back to the core rotations at the end. And we would tweak this based on the resident's, job prospects. If they, had a job they lined up, they were going to be working in abdominal transplant, maybe even giving them a little more time there, or putting that towards the end where they're kind of, focusing on that at the very end, ready to go into that job in July, August, what have you. So just an example of how our program sort of came up with this structure and kind of meeting those ASHP requirements, but also sort of thinking it through to benefit the resident in the best way possible. As far as specific areas that ASHP requires residency programs to cover, there is an appendix to that competency goals and objectives document that really talks about specific areas that ASHP wants the program to have either provide the resident with direct patient care experience or case-based topic discussion approaches or elective experiences. And I'll kind of go through an example on the next slide. But not every single thing they put in there has to have a direct patient care experience associated with it. It depends on your group. If you kind of think about it as a group, if you specifically think that's something that they recommend as a case-based topic discussion approach, but you think that the resident should have direct patient care, discuss that with your preceptors and come up with an approach that satisfies everyone's thoughts and ideas, and ask your residents too, as you kind of go through each year, what they would think that they did not get enough exposure to or wanted a little more structure with. It's always a consistently evaluating that approach every year to year. But I would say ASHP, when they surveyed us, they did want to look at this document. So it's trying to really establish a way to document these discussions is important, whether that be a checklist that you're going to come up with or some type of tracking document, whether it's an Excel or Word document. And I would recommend to try to really pre-specify the rotation that you plan to discuss these. So the preceptors know exactly what they should be discussing on their rotation. So everything is completed before the residency year is over. And this is an example of something that we've done. We have the topic listed, the rotation that we expect it to be on. If it will encompass multiple transplant areas, we kind of just have a general cell organ transplant. But if it's something specific to abdominal, for example, or something specific to lung, that we think they would see more of, like more cytomegalovirus infection in that population, then we would sort of try to dictate it. So each preceptor's workload is split up evenly, and the resident's sort of responsible for making sure that these topics are hit. And then once they're discussed or direct patient care is required for that, they would put the dates in there. So this way it's kind of a longitudinal tracking document. So when ASHP comes for survey, we can kind of show how we're approaching these topics to be discussed and how the direct patient care activities are being incorporated into the program. And kind of falling into the last part of my presentation with the preceptor assessment and preceptor development. So really kind of course, everyone is probably familiar with the preceptor eligibility requirements, for PGY1, PGY2 residencies, making sure that your preceptors are in line with the eligibility to be a preceptor. If they do not meet this criteria here, they probably would have to fall into that preceptor in training, and there are preceptor and training development plans that have to be created. So just paying attention to what qualifies them to be a preceptor from a training or experience level. And then in addition, there is an academic and professional record that should be completed on an annual basis by each preceptor, and making sure that they're in guidance with the ASHP guidelines to make sure that they're meeting the criteria to be a preceptor from that perspective. And this really kind of falls on their involvement in the organization and their qualifications to be reappointed every year. So for example, there's recognition in the area of pharmacy practice that preceptors have to have, and maybe kind of thinking about board certification, advanced degrees, fellow recognition. A lot of these things are actually pretty higher level. Not every preceptor may have this. So really reviewing with your preceptors what the requirements are up front, so everyone can kind of keep up on their requirements from year to year. And lastly, kind of incorporating preceptor development longitudinally, there should be a needs assessment that happens on an annual basis. I have an example of ours on, I think, in 2 slides. And then having a clearly defined schedule for the year. I think it's important to try to really utilize as many resources as possible. So we have a School of Pharmacy not far away from us. So utilizing faculty from the School of Pharmacy, there's other residency programs there, utilizing your hospital preceptors to really kind of think about what topics they're interested in hearing about. And maybe these are things that the preceptors themselves can discuss, but also ASHP offers resources and online programming, trying to get together, well, maybe virtually now via Zoom or Teams or WebEx or whatever platform you have, to try to get the preceptor group together to kind of watch a webinar or watch an online programming that fosters preceptor development, maybe providing resident feedback, etc. The other thing I skipped, sorry, on this bullet point here, university resources. So we have utilized in the past our librarians to kind of go over REDCap tutorials or literature for the preceptors and our residents will attend these sessions as well because it is beneficial to them too. So incorporating your resident in the preceptor development activities is important because they will eventually be a preceptor themselves down the line. And then kind of also really considering assigning, preceptors responsibility to oversee this. So we have 2 of our current preceptors, not within the transplant residency, just in the PGY1 residency, who are responsible for it. So 2 preceptors that sort of come up with the schedule, send out the needs assessment, and this way it's kind of streamlined and it's their responsibility to make sure these things happen throughout the year. And really kind of making sure that you set expectations for preceptor development by having maybe a written policy around this. We do have a preceptor assessment policy, and I believe that ACCP would like to see that, but we also included preceptor development in that preceptor assessment policy. So what of course qualifies you to be a preceptor, but we also added wording that our preceptors are required to attend preceptor development sessions, how many that are offered and how many they're expected to attend. So we expect attendance at least 2 out of the 4 preceptor development sessions per year. So this way, our preceptors know what is expected, and we will always offer that amount or more per year, and everyone's expected to attend too. So this way, you're kind of giving more opportunities for preceptors to attend sessions, but they may be on vacation, et cetera. But this way, at least they'll be able to attend 2 throughout the year. And some of them we are recording as well, but really trying to have it live per se, via a virtual platform just due to COVID-19 restrictions at this point. And this is an example of our needs assessment over here. So we'll send this out on an annual basis. It has some categories that were kind of common, like writing an effective learning experience, mentoring, providing criteria-based feedback. And basically, we have the preceptors sort of score how comfortable they are with these topics. And if we find an area where there's low comfortability, maybe that would be something we would focus on this year. And then at the bottom, the preceptors are able to kind of write in, this is usually sent out through like a Survey Monkey, write in any additional areas that they find challenging or that they want to discuss this year. And then on the right-hand side of your screen is a written topic and schedule. So this is from 2018 to 2019 for our program. And this is what we would, of course, be able to provide to ASHP as to how we're incorporating preceptor development, what kind of topics we're offering, so on and so forth. And I think that comes to the conclusion of my slides. And I'm happy to turn it over to Idris to kind of go through some additional information.
Thanks a lot, Adam. And I also like to thank the organizers of this webinar for inviting me to share my experience, specifically from a new program's perspective. For this portion of the webinar, I'm going to cover some longitudinal experiences that you may want to consider for your residency program. And these are generally approximately 11-month experiences that may not specifically fit into those core elective experiences that Adam talked about. And they generally expose the residents to direct care for solid organ transplant recipients, but also generally to pharmacy practice experiences as well. So, for example, with regards to pharmacy operations, at VCU Health, transplant residents staffs every 3rd weekend in one of the satellite pharmacies, and the assignment of the satellite pharmacy where they staff is specifically tailored to the satellite pharmacy that verifies orders for transplant patients. So they get that exposure of verifying orders for transplant patients, and also being part of the pharmacy operations for the pharmacy department. The resident also participates in pharmacokinetic clinical coverage. So this may not be very specific to transplants, but it allows the residents to continue to develop their skills in regards to pharmacokinetic dosing of medications, specifically anti-infective medications. If you do have an on-call program, so the transplant clinical specialists at my center, we participate in clinical staffing, and we do have an on-call program, so you can to ensure that the resident gets exposure through their staffing model to transplant-specific exposure. We do incorporate the residents into the on-call program as well. So they carry the on-call pager through when they are staffing on the weekends, and they help answer any specific transfer-related questions. And the resident can also participate as part of the code blue response team. Adam talked about the ambulatory care experiences. Again, this can vary depending on the unique transplant centers, depending on how your practice is set up. Ambulatory care experiences can be core experiences, that can be in blocks, or they can be longitudinal in nature. We initially had our ambulatory care experience as a block. So my resident had a 5-week block of kidney transplant experience where he was able to see patients in the pre-transplant clinic, but also follow up with patients in the post-transplant setting. But we had a slight change in how, in our practice model, now we shifted from a block experience to now a longitudinal experience. Try to do with our longitudinal experiences to try to correspond the ambulatory care experience to the inpatient experience to ensure for continuity. So, for example, when the resident is in their inpatient liver transplant rotation, they will spend 1 day a week in the post-liver transplant clinic. So that way they're seeing patients that are discharging from the hospital to ensure that continuity of care. With regards to research project experiences, research projects, we all know about the need to the early deadline for ATC, the American Transplant Congress meeting. So typically, residents have to have their research pretty much completed with data analyzed to submit to the American Transplant Congress meeting. This is something that we highly encourage, and we try to ensure that before the resident comes started at our center, that they had an understanding of, they already selected the research project that we're going to participate in. So that way, once they start their residency, they can hit the ground running with respect to IRB submission and how to go about data collection, and then coming up with a timeline of completing the data collection, analyzing the data, and perhaps submitting an abstract to ATC. In addition to longitudinal research experience, you can also incorporate a medication use evaluation experience that could also lead to potentially a publication depending on the magnitude of the MUE or the results of that project. Other longitudinal experiences, Adam talked about the transplant core topics. Again, this can be direct care. This can be achieved through direct care experience, patient care experiences, but it can also be achieved through topic discussion approach as well. What we do at my center, we have weekly topic discussions with the resident, just essentially put up those ASHP core topics and then assigned the topics based off of the rotation. So kidney transplant topics will be very specific to the kidney transplant rotations. Ambulatory care topics were tailored to specific ambulatory care rotations. And weekly, we meet with the residents, and as a group of preceptors, we discuss the specific topics with the residents. The expectation is to at least have a handout of resident to president handout, and they discuss these various topics throughout the entire residency experience. At our center, we perform very low pediatric volume, so pediatric transplant we couldn't provide a core rotation experience for peds transplant. So this is a longitudinal experience for our residents. Essentially, regardless of what rotation the resident is on, once we have a pediatric transplant case, we ensure that we discuss that case with the residents, but we also ensure that we have pediatric specific topic discussions as well with the resident throughout the entire training with us. Other experiences, scholarship and teaching, so the residents can be involved in co-precepting students or PGY2 residents. If you are at a center that's affiliated with the School of Pharmacy, they can participate in didactic teaching. We recently just started a transplant elective course at our School of Pharmacy, so it allows the residents to at least have an experience with didactic teaching of 1 or 2 lectures outside of perhaps the standard residency teaching certificate program. These are specific transplant experiences that allows the resident to be engaged in unique exposures like this. Other presentation experiences, journal club, case conference. We have a resident also present at the transplant grand rounds, so that way they can get direct feedback from transplant providers. The resident is also involved in the Quality Assurance and Performance Improvement Committee or COPI committee. So I have a resident to be part of the kidney transplant COPI committee. So they meet with that committee meets once a month, and they identify any pharmacy-related issues that comes from those committees. And sometimes there are specific minor projects that may also arise from participation in those committees. The resident also participates in the selection meetings. We tailor the transplant selection meetings to our ambulatory care experiences. So, for example, while they're on their kidney transplant clinic experience, they can participate in the weekly transplant selection meetings. And when they're on their heart transplant experience, they participate in the heart transplant selection meetings. And some residency programs have general leadership development series where we have a series of different topics that you engage residents in a different time frame throughout the residency experience. Or you could also develop a transplant-specific leadership development series where the resident can have specific topics to discuss with some of the leadership members of the transplant team. This allows them you can have specific topics that relates to how to go about preparing your CV, how to go about, applying for your transplant job, or, various topics that may meet the needs of the resident. Additional experiences. Again, these are unique experiences that may not fall within a specific rotation or specific experience. Getting the residents exposed to protocol development or revision. So we ensure that our residents is involved in developing a protocol or revising one or two protocols throughout their residency experience. The pharmacists are very involved in creating power plans or care plans. So getting the residents that exposure, so that way when they get their first job and they get their first job in a transplant center that expects, or this becomes one of the responsibilities that they have to fulfill when they are in their jobs, that at least have that exposure in their residency experience. Other additional opportunities: involvement in institutional, local, and national organizations. The ACCP, IMTR is one example of opportunity for them to get involved in a national organization, getting involved in the ASD, Transplant Pharmacy Community of Practice, or ISHLT as well. These opportunities also give the resident general exposure to what's happening within the transplant pharmacy community. Or getting the residents involved in shadowing or gaining experience about organ procurement organization. What does an organ procurement organization do? What is their role in the transplant process? With regards to service component, the ASD Transplant Pharmacy community organizes the annual organ donation awareness, and I think this is a great example of a service, a service project that the residents can participate in. This year, our resident is working with pharmacy students at the School of Pharmacy to help put about an organ donation awareness activity as part of the Organ Donation Awareness Challenge. Or the transplant resident can also engage in community-specific projects that are geared towards the transplant program or a specific pharmacy organizations. Other specific examples that we try to get the residents exposed to is if one of the preceptors gets, invited to review a paper for journal publication, we try to tie the resident to being involved in experiences like that, so that way they can again continue to broaden their overall exposure in different aspects of their day-to-day activity as a clinical pharmacist. And I think that concludes my portion. I'm going to turn it over to Stephanie.
Hi, so I'm hoping I can provide a little different perspective, having been an RPD and having done residency survey accreditations. So once again, my perspective is a little different, but I hope it'll be helpful. So you've decided to start a residency program. I would highly encourage you to seek ASHP accreditation. There are many upsides to seeking accreditation and very few, if any, downsides. The way I see it, accreditation establishes a framework for policies to protect your organization, policies that set expectations for your candidates, for your preceptors, for your residents, and for your RPDs. It also helps prospective employers and employers such as yourself, if you're looking to hire someone coming out of residency training, you'll have a better idea of what training they've had if they have a ASHP accredited residency. The residency accreditation process does involve a lot of work. It's a lot of paperwork. It can be intimidating. So I hope to help new RPDs understand the process for residency accreditation, and hopefully that'll alleviate some of that intimidation. I hope to give some advice, and I'll discuss some of the more common survey findings that I see when I visit different sites. So understanding the ASHP accreditation process. Once you're in candidate status, and that means that you have you've enrolled a resident and you've applied for accreditation, someone from ASHP, which is typically a lead surveyor, will contact you and they'll set up dates for your survey. 45 days prior to your site visit, you'll submit your pre-survey questionnaire and your required documents. That's a lot of work. It's a lot of paperwork. And then you'll have your on-site or your virtual survey, as it may be during this unusual time. I believe any time in the foreseeable future, all of the surveys are going to be virtual. But the goal will be to gather and accomplish the same, gather information and accomplish the same goals as we would if we were on site. During the survey, a guest surveyor will be present, and that's a practitioner surveyor. That is one of your peers. That's someone who is an RPD or has been an RPD, and it's certainly someone who practices in transplant. And you'll meet with this person along with a lead surveyor who is either an employee or a contract employee for ASHP. During the survey, this group will meet with RPDs. They'll meet with preceptors, they'll meet with the residents, they'll meet with pharmacy leadership, they'll meet with hospital leadership, and they'll even take time to meet with clinicians that practice in transplant. So at the end of the survey, the very last day, the very last thing that they do, there'll be a verbal report out that outlines your program's areas of partial compliance and non-compliance, and they'll also give you consultative recommendations. And it may take up to 30 days for you to receive a written report. So my recommendation is to take notes during that report out so that you can get to work and start addressing these areas of partial compliance and non-compliance, and even start working on your response. The next step is your response. And this is where you have the opportunity to make adjustments and make corrections and make a plan to fix any of the deficiencies you have. And you have 75 days after the end of the site survey. Once you submit your response, that report and the response, the surveyors review it, see what progress has been made, and they submit all of that to the Commission on Credentialing. So some things to know. Number one, the lead surveyor and the practitioner surveyor do not determine your accreditation status or the duration of your accreditation. They are only there to evaluate whether your program meets the required elements of the standard. So they assess whether you're fully compliant with the standard, partially compliant, or not compliant. They make a non-biased assessment of your compliance, and they're also there to help educate you on how to correct those deficiencies and how to meet the standard. The lead surveyor generally starts with their elevator speech, and part of that is that the standard is written to the optimal practice. So the standard isn't a minimal requirement, it's optimal, how in the best case scenario, everything would operate in your residency. And so you'll see that how you're judged against the standard is if whether you're fully compliant. And what that means is that you are compliant with all of the parts of that standard all of the time. And partial compliance is if you're compliant with part of the standard, maybe not all of the standard, maybe it's not consistent in how you practice. And then there's non-compliant, which means you don't fulfill that standard whatsoever. You'll also receive consultative recommendations as part of your report out and as part of your report. Those are only optional, but often they offer opportunities. I know as a guest surveyor, I take the time to assess what your practice looks like at your site. I talk to your preceptors, I talk to the clinical staff, and I ask them if there's areas where they lack support, where clinical pharmacists would benefit patients. And if we're able to identify that, particularly if it's a service that's outlined in the ACCP guideline for pharmacy services in solid organ transplant, I'll often put that as a consultative recommendation because often if that appears in that report, sometimes it really gives you a more substantial case if you want to look at expanding your services later on. So determining your accreditation status, your response is just as important as your site visit. If you are able to run with your deficiencies and you're able to change the practice and provide evidence that you've fixed that issue, once you turn in your response, if you have that evidence, you're now fully compliant with that standard, and that your previous deficiency won't affect your accreditation. So once again, your response is just as important as what you have at your site visit. Even if you aren't able to fully fix any compliance issues, but you're able to show that you've really got a plan in place and that you've started making changes, even that will help you and positively affects your accreditation as well. So any work you do from the time of your site visit to your response can be favorable for your accreditation. Your accreditation is determined by the Commission on Credentialing, and it will either be withheld, it'll be conditional, or now we grant it even up to 8 years. It was previously 6 years, but now it's 8. What a lot of people don't realize is that your compliance with the critical factors determines your length of accreditation. So when you look through that standard, the factors that are in bold, that's really what affects your duration of accreditation. Some of my words of advice: number 1, familiarize yourself with the standard. Go through the copy of the standard that has all the guidance documents. What I find is that everything you need to know is in those guidance documents. If you don't understand or if you have questions, reach out to colleagues at other centers, reach out to me, reach out to ASHP. We're all happy to share. My experience is that now that the standard has guidance documents with it, a lot more centers have a lot less issues with compliance and are fully compliant with a lot more of the standard than they were previously. Make sure you read through and you're familiar with the competency area goals and objectives and the appendix, because that's going to help you design your program in order to meet all of those. And it's going to help you make decisions about making core versus elective experiences, and think about how your resident will be able to have patient care opportunities or topics in some of those more obscure areas of the appendix. If you have the luxury, start designing your program 1 to 2 years before you start your program. It's a lot of work. Share the wealth. Being an RPD is a lot of work. It's a lot of paperwork. It's a lot of keeping up with things. It's a lot of being organized. Utilize your preceptors. You can have a site coordinator that you can designate different responsibilities. I encourage you to do that. It's a lot of work. And most of us don't get a lot of offline time to do these things. Make sure your preceptors own their own rotation descriptions. I've been to programs where the RPD tries to write all of the rotation descriptions, but really the intent is, and when you're surveyed, the surveyors want to know that the preceptors own their own rotation descriptions. And lastly, Standardize your practices and policies amongst all the programs at your center. Most of the time, solid organ transplant isn't the only program at a center, so I would highly encourage you to standardize those so it's less work and less updating for you. So what you might really want to know, and that's some of the more common findings on surveys. I'm only going to bring up a couple of them. I could talk about this all day. The first one I'll bring up, though, is standard 3.4.D, and this talks about evaluations. And this is a critical factor, so it does affect your length of accreditation. Number one, the RPD, the preceptors, or the RAC should have defined your evaluation ratings. So if you still use needs improvement, satisfactory progress achieved, there should be definitions for this, and they should be documented. Most people will either house that policy in Pharm Academic, or they'll house the policy in the residency manual. The other thing I'll tell you about this is something I always ask about when I go to different sites. Not only do you have a policy, but can the preceptors speak to it? So make sure that they're able to do that. Also, when I do a survey, I spend a lot of time digging in Pharm Academic. That's where I spend most of my time. And I look at the quality of the evals, and I look at different aspects of them. Things you do get evaluated on this. Are the written comments specific and actionable? Do they use criteria related to the educational objectives? Things I look at, do they speak to the quality of the work? Are they able to provide an assessment of how well the resident did and why they were assessed that way, rather than just restating what the resident spent their time doing over the last month? Some of the evals I see say the resident saw patients, prior to discharge, they educated them, and, they gave some in-services, but were you able to speak to how well they did that and what things they could do to improve their performance? What could they do to achieve that goal in the future? Did you comment on how they progressed through the rotation? Are they where they should be at that point in the residency? All of those things should be in all of your quality written evaluations. And this one, I think, gets cited a lot because, we look at all of the preceptors, all of the evaluations, and in order to be fully compliant, ideally, it should be that way 100% of the time. And this is the other thing that I see a lot is, remember, the standard says that evaluations should be completed by the due date, if it's stricter than 7 days, or within 7 days of the end of the rotation, and that you should be reviewing that in person with the resident. The other thing I'll remind you of is that resident evaluations, whether they're doing all the evaluations, whether they're discussing it with their preceptors, and if they're timely, that also counts. That's part of the standard too. So it's not just are the preceptors doing their work, but are we keeping up with our residents too? What they do affects our accreditation. Lastly, I'm not going to get too much in depth on what these policies should say, but I will say that this is probably the standard that encompasses the most, that really makes it hard to be fully compliant, because standard 1.7 and 2.4, some of these elements also tie into 1.6, 1.7, 2.1 in multiple different standards. So it makes it really difficult to be fully compliant. So what I would encourage you to do is pull these standards, see exactly what is in the guidance document, see exactly what ASHP is looking for, look in the guidance document. The other hint I'll give you is if you really explore on ASHP's website under residency resources, a lot of these type of documents are there as examples. So I would definitely look at that. Requirements for completion, make sure you have very objective deliverables. What has to be done? How many presentations? Can you define how many weekends they need to staff? What percentage of goals and objectives have to be completed? Are there certain ones? So once again, I don't have time to dive too much into this, but just keep in mind, pull out your guidance, use it as a checklist, have someone double check you, because this is probably some of the more tricky ones, the policies in place. I'm going to stop there and turn it back over to Matt, because I think we hope to take some questions.
Yeah, I wanted to thank the panel very much for such a very informative presentation. We're close to the hour, right at the hour, but I wanted to give the audience an opportunity to, if they had any questions they'd like to ask of our very knowledgeable panel members. And if you could you please type it in the presenter chat? And while we're waiting, I have a question for the group. When Stephanie accredited my program, she gave me a consultative recommendation about assessing burnout and well-being. And I'm just wondering if any of the other panelists formally do this for their residents, and if you do, how do you do it, and how often do you do it?
This is Teena. I don't know if you guys can hear me now, but one of the things that we instituted this year was we do a monthly RAC report. So it's something that the residents, all of our residents, and it's standardized across programs, fill out prior to RAC. And some of the items that we listed, we have them kind of go through and answer specific questions on well-being and burnout. So we use that at least as a tool to perhaps assess and identify opportunities. And I think the RAC report, to be honest, has been really helpful because it helps them really evaluate kind of their why, where they are, and allows us to probably make more timely changes to programs and kind of interventions before it gets maybe too late and they do get to that point of burnout.
Hey, Matt, this is Adam. Can you hear me?
I can.
Yeah, no, this is a great point, I think. We had Lonnie Smith come for our accreditation. He kind of mentioned something similar to us, not an official consultative recommendation, but something along the lines of asking how we may do that. I would say we haven't incorporated something like Teena has, which I think, is a great idea. I definitely encourage our residents to, on the quarterly basis, when we do fill out their development plans that happen on a quarterly basis, I always have them reflect on some type of personal goal or something that they find that they need to improve on personally. So for example, like this year, our current resident talked about work-life balance, and that kind of relates to burnout. And then, not only saying, oh yeah, okay, you work on that, sort of like how they're going to work on that, always trying to kind of incorporate that, I think, in that discussion, but it probably could be something you could reflect on more frequently than quarterly. But we do try to incorporate that at least somewhat throughout the program. And always just trying to do a check-in, for the residents' mental health, for sure.
Yeah, both of those sound like great ideas, which I might steal a little bit from my program. We actually have a question from one of the audience members, and I totally relate to this question. It says, do you have any recommendations related to making the farm academic evaluation process less cumbersome and able to be completed within 7 days of rotation completion?
I can kind of speak to that. One thing I would do is look and see how many goals and objectives you're evaluating in each rotation. If you're evaluating most of them or half of them or many of them, I would not do that. I would look at how you're evaluating, and maybe some of those lower level goals and objectives evaluate in your early rotations and sort of limit it there. And then keep some of the more advanced goals and objectives and evaluate those in some of the later, but really make sure you're limiting how many you're evaluating. The other thing I think most of us do well if we have other people depending on us for a deadline. So something our program often does is the RA will sit down with the preceptor at the end of the rotation. They'll have a scheduled appointment to go through the evaluation. And so if you have that scheduled ahead of time, it sort of presses on you that you have to have it done. So those are a couple things I think might be helpful.
From an accreditation standpoint, is there a certain amount of times each objective must be evaluated before it can be marked as achieved, or I'm worried about if you get to the end of the year and you don't have a certain objective marked, how do you handle that from an accreditation standpoint?
So I would recommend evaluating every goal and objective at least twice. And remember, as you do your quarterlies, you can customize your program. So if you have a resident that is struggling in one area, you can modify some of your later rotations to make sure that if they haven't achieved that goal, that you focus on that in later rotation and make a point to really give them the opportunity to achieve that skill, if that makes any sense. And that should be part of your customization and part of your quarterly assessment.
Thanks for sharing. Well, we're at 5 after the hour, and I'm not seeing any more questions in the chat box. And so I just wanted to remind everybody that these slides will be placed online. And then if you could please fill out the evaluation once it's concluded. And I'd like to thank our panels for a very thorough and informing presentation on establishing and growing solid organ transplant residency programs.